Welcome to the Deep Dive. Today we're really zeroing in on something absolutely vital for anyone heading into pediatric nursing. We're talking about hematologic and immunologic dysfunctions in children. We've pulled together some key info, mainly looking at Chapter 28 from Wong's Nursing Care of Infants and Children. Think of this as, well, a focused look at understanding these conditions in young patients.
That's right. And for you future nurses listening, it's more than just memorizing symptoms. It's about grasping the why, the pathophysiology. So your nursing care is truly informed, truly effective. Our goal today is basically to highlight the essentials, how these disorders work, what you'll see, and crucially, the nursing interventions and treatments you'll be part of.
And, some of these concepts can get a bit complex, so we're really pleased to have our expert joining us to help bring some clarity. Welcome.
Thanks. It's great to be here. Happy to help break down these important topics for nursing students.
Okay, fantastic. Let's dive right into the hematologic system. The blood, its components. Wong's breaks it down. Red blood cells, white blood cells, platelets, plasma, maybe a quick refresher on their basic jobs and why it matters so much when things go wrong.
Absolutely. So think of blood as like the body's main transport network. Red blood cells, they're your oxygen carriers, super vital. White blood cells are the immune defense team fighting off infections. Platelets are the first responders for repairs, stopping bleeding by clotting. And plasma, well, that's the liquid highway carrying everything else, nutrients, waste, all those cells. So if any part of the system gets disrupted number of cells, their function, it throws everything off. And for nurses, spotting that disruption is step one.
That totally makes sense, which leads us nicely to anemia. The source defines it as a drop in red blood cells or hemoglobin, so less oxygen getting around. This is pretty common in kids, isn't it?
Oh, absolutely. Reduced oxygen carrying capacity is the core issue, leading to tissue hypoxia. And you're right, Wong's really highlights iron deficiency anemia. It's the most common one you'll encounter in pediatrics.
Right, iron deficiency anemia. From a nursing angle, why is it so common in children? What should we be looking out for?
Well, several things contribute. Kids grow fast, right? Especially during certain spurts. Their iron needs shoot up, and sometimes diet just doesn't keep pace. Picky eating doesn't help, obviously. And inadequate intake of iron-rich foods is a big factor. Plus, even slow, chronic blood loss, maybe not obvious, can deplete iron stores over time.
So if we suspect it, what are the telltale signs? What would a nurse actually see in a child?
Okay, common things. Pallor is a big one. That noticeable paleness, skin, mucous membranes. You'll often see fatigue, just general lack of energy. Irritability is common too. And sometimes the heart tries to compensate for the low oxygen, beating faster, so you might notice tachycardia.
And if we look at the labs, what confirms it?
Key labs would be low hemoglobin and hematocrit H&H. That directly shows fewer RBCs or less hemoglobin. Low ferritin is also really important. That measures stored iron. And under the microscope, the RBCs themselves often look different. They're typically microcytic, smaller than usual, and hypochromic, meaning paler because of less hemoglobin.
Okay, so the signs are there, the labs fit. What's the nursing care plan? What treatments are involved?
Treatment number one is usually iron supplementation, often ferrous sulfate. Our job as nurses involves a lot of education here. We need to teach families how best to give it. Stress taking it on an empty stomach if possible, and definitely with vitamin C like orange juice because that boosts absorption significantly. But you also have to warn them about, potential GI upset, constipation, and the fact that liquid iron can stain teeth. Dietary teaching is also huge, encouraging iron-rich foods, meat, poultry, fish, leafy greens.
Got it. Okay, let's switch gears to sickle cell anemia. The chapter notes this is genetic. What's happening at the cellular level?
Yes, it's an autosomal recessive disorder, so a child needs to inherit the faulty gene from both parents. The problem is an abnormal hemoglobin, hemoglobin S. Under certain conditions, low oxygen, dehydration, fever, even stress, this hemoglobin S makes the red blood cells, which are normally round and flexible, become stiff and, well, sickle-shaped.
And what are those specific triggers nurses need to be aware of? The things that can kick off a sickling episode.
Key triggers include things like fever, getting dehydrated, hypoxia, meaning low oxygen levels, significant physical or emotional stress, even exposure to extreme cold. Helping families recognize and ideally avoid these triggers is a big part of nursing management.
The source talks about different types of sickle cell crises. Can you kind of walk us through the main ones and what nurses need to watch for?
Sure. The most common is the vaso-occlusive crisis, or VOC. Those sickle cells basically clog up small blood vessels. This blocks blood flow, causing ischemia and, importantly, intense pain. Patients might present with pain in their bones, joints, chest, abdomen, often with swelling and fever. Then there's splenic sequestration. This is serious. Blood pools rapidly in the spleen gets enlarged, and the child can quickly become hypovolemic, potentially leading to shock. It's an emergency. And a plastic crisis. This is when red blood cell production in the bone marrow temporarily stops, often triggered by an infection like parvovirus B19. You'll see a sharp drop in hemoglobin.
Wow, those sound incredibly serious. What are the immediate nursing priorities when a child comes in with a sickle cell crisis?
Top priorities are managing the acute symptoms and preventing complications. Think HOP, hydration, oxygenation, pain management. So aggressive IV fluids are crucial to help dilute the sickled cells and improve blood flow. Supplemental oxygen if they're hypoxic. And effective pain control is paramount. This often means opioids, maybe on a schedule or via PCA pump. Don't under-medicate the pain. Long-term, there's hydroxyurea. It's a medication that helps increase fetal hemoglobin production, which doesn't sickle as easily. Regular blood transfusions can also reduce the percentage of hemoglobin S. And preventing infection is key prophylactic penicillin, especially in young kids, and making sure they get all their vaccines, particularly pneumococcal.
Okay, moving along. Thalassemia, sometimes called Cooley's anemia. What's the core issue here physiologically?
With thalassemia, the basic problem is a genetic defect that messes up hemoglobin synthesis. Specifically, one of the globin chains that make up hemoglobin isn't produced correctly, or maybe not at all. In beta thalassemia major, or Cooley's anemia, there's a severe lack of beta globin chains. This leads to unstable hemoglobin, rapid red cell destruction, and chronic, severe anemia.
So, as a nurse, what signs and symptoms would make you think of thalassemia?
Well, because of the chronic anemia, you'll see significant pallor again, fatigue, weakness. Growth can be retarded. And the body tries so hard to make more red blood cells that the bone marrow expands, which can cause characteristic bone changes like frontal bossing, an enlarged forehead, or maxillary hyperplasia. You might also see an enlarged spleen and liver splenomegaly, hepatomegaly, from the increased breakdown of red blood cells.
What does the nursing care and treatment look like? It sounds like pretty intensive long-term management.
It absolutely is. It's often a lifelong thing. The main treatment involves regular blood transfusions, maybe every 2 to 4 weeks. The goal is to keep hemoglobin levels up and suppress the body's own faulty red cell production. But all those transfusions lead to a major complication: iron overload. So, iron chelation therapy is vital. This removes the excess iron. Deferoxamine is a common drug, often given as a slow subcutaneous infusion overnight via a pump. A bone marrow transplant or hematopoietic stem cell transplant can be curative, but it's not an option for everyone. Nursing care also involves managing transfusion reactions, side effects of chelation, and lots of psychosocial support for the child and family dealing with this chronic illness.
Okay, let's touch on aplastic anemia. The text describes it as bone marrow failure. What does that mean for the different blood cell counts?
Exactly. Aplastic anemia means the bone marrow just isn't producing enough of any blood cells, red cells, white cells, and platelets. This condition is called pancytopenia, pan meaning all, cyto for cell, hyperemia for deficiency, so a shortage of all cell lines.
What kinds of things can cause this bone marrow failure in kids? Are there specific triggers nurses should know about?
Well, frustratingly, in many cases, it's idiopathic, meaning we don't know the exact cause. But potential triggers can include exposure to certain toxins, some medications, viral infections like parvovirus or Epstein-Barr, and some rare inherited conditions.
With deficiencies across the board, what would a nurse likely observe clinically?
The symptoms directly reflect the missing cells. Low RBCs cause fatigue, pallor, weakness. Low WBCs, especially neutrophils, mean a high risk of infection, so fever, maybe sepsis. And low platelets or thrombocytopenia lead to bleeding, easy bruising, petechia, nosebleeds, that sort of thing.
How is it definitively diagnosed? Is there a key test?
Yes, the gold standard is a bone marrow biopsy. In aplastic anemia, the biopsy shows markedly reduced cellularity, far fewer blood-forming cells than normal. It's described as hypocellular.
And the main nursing considerations and treatments?
Nursing care is heavily focused on supportive measures. Preventing infection is huge: meticulous hygiene, protective isolation if needed, monitoring closely for any sign of infection, and giving antibiotics quickly if one develops. Bleeding precautions are also critical, and platelet transfusions might be needed. Treatment aims to get the marrow working again. One approach is immunosuppressive therapy, using drugs like cyclosporine and ATG to stop the immune system if it's attacking the marrow. For severe cases, or if immunosuppression doesn't work, a hematopoietic stem cell transplant, a bone marrow transplant, is often the preferred treatment, replacing the halting marrow. Red cell transfusions are also used to manage the anemia symptoms.
Okay, let's shift to bleeding disorders, starting with hemophilia. The genetic link is emphasized. How is it passed down?
Right. Hemophilia is X-linked recessive. The genes for the affected clotting factors, factors 8 and IX, are on the X chromosome. Since males have one X and one Y, if they inherit an X with the faulty gene, they'll have hemophilia. Females have two X chromosomes. They usually need the faulty gene on both X's to have the disorder, which is rare. But if they have it on one X, they're carriers and can pass it to their sons.
And the book distinguishes hemophilia A and B. What's the key difference nurses need to know?
The difference is simply which clotting factor is deficient. Hemophilia A is a factor 8 deficiency, much more common. Hemophilia B, sometimes called Christmas disease, is a factor IX deficiency. Clinically, though, how they present with bleeding is very similar.
So what are those characteristic signs of bleeding a nurse might see?
The big ones are prolonged bleeding after any kind of injury, even minor cuts or dental work. Spontaneous bleeding, especially into joints called hemarthrosis, is really characteristic and painful. It can cause long-term joint damage if it's not treated promptly. Easy bruising, nosebleeds, and sometimes bleeding into muscles are also common findings.
What's crucial for nursing care and treatment, both for acute bleeds and long-term?
The absolute cornerstone is factor replacement therapy, giving the missing clotting factor intravenously. This can be done on demand to treat an active bleed or prophylactically on a regular schedule to prevent bleeds, especially in severe cases. For mild hemophilia A, there's a drug called desmopressin, or DDAVP. It can help release stored factor 8. During an acute bleed, remember rice rest, ice, compression, elevation. Helps control swelling and bleeding. Injury prevention is huge, lots of education about safe activities, protective gear, and it's critical to teach families to avoid aspirin and NSAIDs like ibuprofen because they interfere with platelet function and worsen bleeding. Teaching families to recognize early signs of a bleed and often how to administer factor at home is also a key nursing role.
Okay, let's talk about idiopathic thrombocytopenic purpura ITP. It's described as acquired. What does that mean? How does it happen?
Right, acquired means you aren't born with it. It develops later. ITP is basically an autoimmune disorder where the body's immune system mistakenly attacks and destroys its own platelets. Idiopathic means we often don't know the exact trigger, but very commonly it pops up a few weeks after a viral illness.
So if a nurse sees a kid with sudden bruising, petechiae, asking about recent colds or viruses is important.
Definitely. Asking about recent fever, runny nose, any viral type symptoms in the preceding weeks is a key part of the history taking.
What are the main signs and symptoms beyond the bruising and petechiae?
Well, besides the purpura and petechiae, you might see bleeding from mucous membranes. Nosebleeds are common, bleeding gums. In teenage girls, maybe unusually heavy periods.
And what platelet count would really raise a red flag?
In ITP, the count often drops dramatically. A count below 20,000 per cubic millimeter is considered severely low and carries a significant risk of serious bleeding. Normal is usually over 150,000.
So what are the nursing priorities and treatments for ITP?
It depends on the severity. For mild cases with minimal bleeding, often it's just watchful waiting, monitoring the platelet count. If bleeding is significant or the count is dangerously low, treatment aims to boost the platelet count or reduce their destruction. Options include IV immunoglobulin, IVIG, which kind of distracts the immune system from the platelets, or corticosteroids like prednisone to suppress the immune response. Nursing care involves safety precautions, avoiding contact sports, activities with high risk of injury, and again, avoiding aspirin and NSAIDs. Splenectomy is sometimes considered for chronic or resistant cases, but that's less common now.
Okay, last one in this section. Disseminated intravascular coagulation, or DIC. The book stresses it's usually secondary. What underlying issues can trigger DIC in kids?
That's a key point. DIC isn't usually a primary disease. It's a complication of something else really serious. Common triggers in pediatrics include severe sepsis, major trauma, extensive burns, some cancers like leukemia, and sometimes complications around birth for newborns.
Disseminated intravascular coagulation. That sounds like clotting is out of control. What's actually happening?
It's a complex and dangerous process. Something triggers the clotting cascade to go into overdrive throughout the body. This leads to widespread formation of tiny clots in small blood vessels, which can block blood flow and damage organs. But here's the paradox. While all this clotting is happening, the body uses up its clotting factors and platelets. So simultaneously, the patient loses the ability to form normal clots where needed, leading to a high risk of severe bleeding. It's clotting and bleeding.
So nurses might see signs of both clotting and bleeding at the same time.
Exactly. You might see signs of poor perfusion, maybe cyanosis in fingers or toes due to microclots, but also oozing from IV sites, widespread bruising, petechiae, or even major internal bleeding.
What lab results help nail the diagnosis?
DIC labs show a characteristic pattern, though it can be complex. You'll typically see prolonged clotting times like PT and TTT are longer than normal. D-dimer levels, which measure clot breakdown products, will be significantly elevated. And the things being consumed, platelets and fibrinogen, their levels will usually be low.
Given how complex and serious this is, what are the main goals for nursing care and treatment?
The absolute most important thing is to treat the underlying cause that triggered the DIC. If it's sepsis, treat the sepsis. If it's trauma, manage the trauma. Supportive care is critical. Managing the bleeding might require transfusions of platelets, fresh frozen plasma for clotting factors, and sometimes cryoprecipitate, rich in fibrinogen. Maintaining organ perfusion and oxygenation is vital. It involves really close monitoring of vital signs, lab values, clinical status, watching for signs of bleeding or thrombosis, and adjusting treatment rapidly.
Okay, that covers the specific hematologic disorders. Before we jump to immunology, Wong's also covers blood transfusion therapy. What are the absolute must-knows for nurses giving blood products to kids?
Right, transfusions are common in these conditions. Safety is paramount. First, meticulous verification. Check the order, get consent, and then the two-nurse check at the bedside, verifying the patient ID against the blood product label. Every detail must match. Get baseline vital signs right before you start. Monitor super closely, especially in the first 15 minutes, for any sign of a reaction fever, chills, hives, itching, trouble breathing, changes in vitals. Any reaction, stop the transfusion immediately and notify the provider. Crucially, only ever use normal saline with blood products, no other 4V fluids or meds in the same line. And aim to complete the transfusion within 4 hours from the time it leaves the blood bank to minimize bacterial growth risk. And, of course, thorough documentation of everything. Checks, vitals, start-stop times, volume infused, patient response.
Excellent points. Okay, let's shift now to immunologic disorders. The chapter starts with a basic immune system overview. For nursing students, what are the key concepts and why are kids particularly vulnerable?
Okay, super simplified. The immune system has two main arms. Innate immunity is your general, rapid first defense, like skin barriers and cells that eat invaders. Adaptive immunity is more sophisticated. It involves T cells and B cells that learn to recognize specific pathogens and create memory, so the response is faster and stronger next time. Kids are more vulnerable because their adaptive immune system is still maturing. They haven't built up that library of immune memory from exposure yet. This makes them more prone to infections and also immunodeficiency issues.
Makes sense. First up is HIV/AIDS in children. How do kids typically get HIV, and what does that mean for prevention?
The main route by far is perinatal transmission mother to child during pregnancy, birth, or breastfeeding. So, prevention of mother-to-child transmission, PMTCT, is absolutely critical nursing work. This involves screening pregnant women, getting HIV-positive moms on antiretroviral therapy, ART-T, managing labor and delivery carefully, and advising on safe infant feeding. Transmission via blood products is thankfully very rare now in places with good screening.
What signs or symptoms in a child might make a nurse think about HIV?
Early on, signs can be vague. Failure to thrive, FTT is a big one. Poor weight gain, growth issues. Chronic diarrhea is common. Recurrent infections, especially opportunistic ones, things healthy people don't usually get. Persistent oral thrush. Enlarged lymph nodes.
And how is it diagnosed? Is it different for infants versus older kids?
Yes, it is different because infants carry maternal antibodies for a while. So in infants under about 18 months, you need virologic tests like PCR, which detects the virus's actual genetic material. In older children, standard antibody tests, like those used for adults, are accurate.
What's the core nursing care and treatment for kids with HIV? You mentioned ART.
Yes. RRT antiretroviral therapy is the foundation. It's usually a combination of drugs to suppress the virus, keep the immune system as strong as possible, and prevent disease progression. Medication adherence is absolutely crucial for R2 to work. So a huge nursing role is education and support for families around taking meds consistently, managing side effects. Preventing opportunistic infections is also key. For example, prophylaxis against PCP pneumonia with drugs like Bactrim is common. Immunizations need careful thought. Live vaccines, like MMR and varicella, are generally avoided if the child's immune system is severely compromised. Regular monitoring of growth, development, viral load, and CD4 count, a measure of immune function, is essential.
Okay, next. Severe combined immunodeficiency, or SCID. The chapter calls it a primary immunodeficiency. What does that mean, and what's wrong with the immune system?
Primary immunodeficiency means it's genetic, something you're born with. A fundamental piece of the immune system is missing or defective. In SCID, the defect is profound, affecting both T cells and B cells. These are the key players in adaptive immunity. Without functional T and B cells, the child basically has no adaptive immune defense. They're incredibly vulnerable to severe, life-threatening infections from bacteria, viruses, fungi, everything.
What are the early red flags a nurse might see in a baby with SCID?
These infants often get sick within the first few months. They have severe, persistent infections that don't clear up easily. Pneumonia, sepsis, chronic diarrhea. Failure to thrive is common. Persistent oral thrush that doesn't respond well to treatment. They might also have bad reactions to live vaccines if they accidentally receive them before diagnosis.
What's the main treatment offering hope for SCID, and what's crucial while waiting?
The definitive, potentially curative treatment is a hematopoietic stem cell transplant, a bone marrow transplant, ideally from a matched donor. This gives the child a new, healthy immune system. While awaiting transplant, or if transplant isn't possible, managing them is all about protection. Strict protective isolation to prevent any exposure to germs, prophylactic antibiotics, antifungals. IV intravenous immunoglobulin can provide some temporary passive immunity with borrowed antibodies, and absolutely no live vaccines for any infant suspected of having SCID.
Then there's Wiskott-Aldrich syndrome. What are the classic features nurses should recognize?
Wiskott-Aldrich is also an X-linked primary immunodeficiency, so mostly affects boys. It has a characteristic triad. 1, eczema, often severe. 2, thrombocytopenia, low platelets, leading to easy bruising, petechiae, bleeding issues. 3, recurrent infections because of defects in both B cell and T cell function.
And nursing care and treatment for Wiskott-Aldrich.
Again, stem cell transplant is the only cure. Otherwise, management focuses on the triad. Careful skincare for the eczema emollients, maybe topical steroids. Platelet transfusions might be needed for bleeding due to the thrombocytopenia. Aggressive treatment of infections with antibiotics, antivirals. IgG is often used regularly to bolster immunity. And, like other severe immunodeficiencies, avoid live vaccines.
Lastly, the chapter touches on autoimmune disorders, using systemic lupus erythematosus, SLE, as an example. What's the basic problem in autoimmunity like lupus?
In autoimmune diseases, the immune system gets confused. It mistakenly identifies the body's own healthy tissues as foreign and attacks them. This causes chronic inflammation and damage. SLE is systemic, meaning it can affect many different parts of the body: skin, joints, kidneys, brain, blood cells, you name it.
What common signs might make a nurse suspect SLE in a child? The chapter mentions a rash.
Yes, the classic butterfly rash across the cheeks and nose is a well-known sign, though not everyone gets it. But symptoms can be really varied. Persistent fever, joint pain or swelling, arthritis, extreme fatigue are common. Kidney involvement is serious and needs monitoring. Look for swelling, changes in urine. Because it can affect so many systems, the presentation can be really diverse.
And how is SLE managed? What are the nursing and medication approaches?
There's no cure, so management aims to control symptoms, reduce inflammation, prevent organ damage, and minimize disease flares. Medications are key. Corticosteroids like prednisone are often used, especially during flares, to quickly reduce inflammation. Immunosuppressants like methotrexate or mycophenolate might be used long-term to calm down the overactive immune system. NSAIDs can help with pain and mild inflammation, and anti-malarial drugs, particularly hydroxychloroquine, are very commonly used. They help with skin and joint issues and seem to reduce flares overall. Nursing care involves monitoring for flares, checking for medication side effects, educating the family about this chronic illness, supporting them, and encouraging healthy lifestyle choices.
This has been incredibly detailed and really helpful. Just to kind of wrap things up, what are some big picture nursing principles that cut across all these different pediatric, hematologic, and immunologic conditions?
Yeah, there are definitely some common threads. Preventing and managing bleeding is paramount in conditions like hemophilia, ITP, or even aplastic anemia due to low platelets. Infection prevention and control is absolutely critical in all the immunodeficiencies, and also in conditions like sickle cell or aplastic anemia where infection risk is high. Early recognition is key. Promoting normal growth and development is a major goal, ensuring good nutrition, managing symptoms so kids can thrive as much as possible. Providing psychosocial support and thorough education for both the child and the family is essential. These are often chronic, complex conditions that impact daily life significantly. And nurses are constantly monitoring labs, watching for transfusion reactions, understanding the many medications: iron, factor, hydroxyurea, IVIG, immunosuppressants, their uses, administration, side effects. It's a lot to track.
Absolutely vital points for our listeners, our future nurses. Thank you so much for breaking all this down for us today.
It was my pleasure. Glad I could help.
So there you have it, our deep dive into pediatric hematologic and immunologic dysfunctions. We've navigated some complex territory, from blood cell disorders to immune system failures, always aiming to connect the dots for you as future nurses, focusing on what you need to know for excellent patient care.
And just keep connecting that pathophysiology to what you see at the bedside and how your nursing actions make a difference.
Which brings us to our final thought for you to consider. Given how interconnected the blood and immune systems are, and how these conditions are often chronic, what are some of the unique long-term challenges nurses face in providing truly holistic care? How can we best support not just the physical health, but the overall well-being and empowerment of these children and their families, helping them navigate life beyond just the acute episodes? Something important to think about as you continue learning in this vital field of pediatric nursing.